you so much for coming to our lightning talk, harm reduction best practices for practitioners. And these are lessons learned from a qualitative study that we did. I'm Brie, and you're going to hear from Meg a little later. We're both social work professors from Westchester University who have different experiences working in harm reduction. And we were really excited to explore harm reduction's social services available to and provided to youth approximately ages 14 to 26 who trade, sex, and use drugs. And we wanted to learn more about the relationships and how micro, mezzo, and macro systems are navigated and how advocacy worked out in the field. Our research question was, what are the challenges and successes experienced by harm reduction social service providers who work with youth involved in sex trade and/or drug use?
At this point in the project, we are in the preliminary phase of data collection and data analysis. We've conducted 6 semi-structured, in-depth interviews with participants working in social services who work with youth and who have a harm reduction and relational approach to that work. Each interview has lasted between 45 to 90 minutes. And ultimately, we hope to do 20 to 30 overall interviews by the end of the project or until we meet saturation. We're using grounded theory approaches to qualitative research, and we are collecting data and analyzing the data at the same time. We want to discuss 2 preliminary findings that we're excited to explore further. At this point, for now, we've divided our preliminary findings into successes and challenges based on our research question. So in terms of successes, participants identified advocacy strategies. So they've both talked about the tools that they've helped clients build to be able to self-advocate, and then the staff's personal experience advocating within systems that clients regularly interacted with. And a lot of those conversations centered around relationship building. A challenge that staff have discussed is a conflicting practice approach with the realities of systemic oppression and stigma. So what that means is that staff have this personal philosophy or agency philosophy grounded in harm reduction and in building relationships. However, that doesn't always carry over into the structures or the logistics of the systems that clients are navigating. And so they struggle with that on a daily basis with themselves and other coworkers in terms of figuring out the best approach to support their clients. When referencing a conversation with a physician, participant 2 shared the following. We're bringing this person to the ER. Can you make sure they get whatever medication they need to keep them there? If they are unwell, they are going to walk out of there even if they're in pain, because the idea of being sick is way worse than whatever pain they're in. So can you make sure they get tons of methadone, get fentanyl patches, Suboxone, whatever it is that they need that's going to keep them in that hospital? Can you make sure they get that? Prescribe it to them. Do a case conference with the prescribing physician so that they can prescribe it to them. Otherwise, this person is going to walk out of your ER and a few days later end up back in there. And then they're going to walk out again, and you're going to see the quality of care that you're providing is terrible, because that person will keep coming back to your ER for something that could have been preventable. To me, that is a creative solution, although more on a system range. In terms of a challenge, participant number 1 shared, one of the DHS clients I have is 16, and she has school 5 days a week, 2 therapy appointments a week, 1 BB appointment, 1 MAVA appointment, a curfew with her foster parents. She has 2 transports a week for community building, and she has a meeting with me once a week. And she has 0 time to experience being a 16-year-old girl. It's amazing she has support accessible to her, but I personally think we're not allowing people The space to be an independent, self-supporting adult who can make her own decisions. At 16, with the experiences she has, she's not underdeveloped, yet she doesn't know the world around her. After being trafficked and being in sex work, if we're trying to support her and facilitate better life decisions, we should give her the opportunity to make them. But it's hard for her to have the ability to do so when her schedule is 80 hours a week that is micromanaged by a PO. Participant 2 shared, "It's a frustrating place because supporting staff who are constantly in that gray zone, again, of like wanting to support a client but having no resources, or the resources exist but you as a provider have to put in all the work to connect someone to the provider who's supposed to be doing that work. And that's also a difficult thing to ask somebody to do continuously when there's not the resources for that."
Harm reduction best practitioner approaches we have found so far, and this is also based in the literature, is around relational social work. And what does relational social work means? It means connecting with your clients and encouraging safety and trust to be built between the relationship with the individuals you're working with, and then also for them to mirror and have a parallel process. We want to practice being non-judgmental, which is very important for harm reduction. Be very client-centered, and also engage at the same time in trauma-informed practices. So the next steps are, we are going to continue to gather data and code and disseminate this information, and we definitely want to illuminate barriers faced by stigmatized and oppressed communities as they're navigating social, medical, and legal services. We're really excited that you were interested in our work today, and we hope that you'll get in touch with us to stay up to date with our project, and thanks again for listening.